Hello, this is Nathan Radcliffe, and welcome to Interventional Mindset. I am thrilled to have Dr. Arsham Sheybani here from WashU. Welcome, Arsham.
Hey, how are you, Nate? Good seeing you.
Good, good. So I want to talk to you and pick your brain on one of the biggest challenges or opportunities that we have right now in glaucoma, and that is tapping into standalone MIGS type procedures. We have lots of patients with glaucoma. We know they're on too many drops. They're dry. They have problems. They're progressing. But sometimes, taking that leap to the operating room just seems like a hurdle. And I think most of us want to do more of it, but aren't doing it. So, tell us your thoughts and, how do we get going down this pathway?
Yeah, Nate, that's I think a really good topic. Before when all we had were like tube trap options as a standalone, I think there were a lot of patients that were being undertreated by that. I mean, we kind of left people to show like severe progression before we decided to operate. So now you're kind of behind the eight ball. And the MIG space, whether you argue like how useful is it compared to trab or tube, that's not really the point. It's about, are we able to prevent vision loss before it gets severe enough to need a trab or tube? And I think we're starting to build evidence that we can. But as a standalone thing, we don't have a lot of like FDA approved options. I mean, really all I can think about, and you might add to it, but it's classes which are goniotomies, so like GAT, KDB, trabectome, or ECP, which again now is like bundled with cataract surgery, or options like Zen when you're talking about subconch filtration. And I can tell you, if we're looking at MIGS alone, our volume when it comes to standalone is probably highest with Zen. I'm not sure it's even close, to be honest, but that's because partly labeling. There are certain TM stenting I would love to do as a standalone, but if they're not on label and it's going to be an out-of-pocket expense for patients, I just don't do cash glaucoma. Now, speaking just from experience, like we do GAT, especially like secondary open-angle glaucomas. For partial goniotomies, I'm a big fan of that with phaco. There's not a lot of cases where, and I don't even think of one where I've done that as a standalone procedure, just because we have options for larger goniotomies. But with Zen, man, we are 25% of our cases are combined with cataract surgery, but then 75% of them are as a standalone operation. And that's really kind of our big gun MIG surgery that we can do without needing to do phaco.
Yeah, so it's really interesting. The one thing you need for standalone is safety,
Yeah.
safety, safety, and Zen definitely has that. I would agree. For myself, my biggest standalone is Zen.
Hmm.
And it doesn't make a difference whether there's a phaco in there or not. So that's a big.
It's safety too, but it's also the ability to get the pressure down. Because if you're going in for the cataract and their vision's not great, they're going to get a benefit. And if your pressure surgery, they're already controlled or whatever, and you do something and you don't get them off drops like you wanted, it's not the end of the world. If you're going in for the glaucoma and you're taking them to the OR to lower their pressure, you better damn well make sure that what you're doing is going to have a high likelihood of achieving that. And so, like goniotomies, they're like it's going to be very select patients where that might work as a standalone. And then even GAT, a large stripping one, you got to pick it right. Whereas outside of like angle closure glaucoma, where again phaco there would be kind of my MIGS like procedure for glaucoma. Most of your open angle glaucomas outside of like uveitis or neovascular glaucomas, when you're looking at MIGS surgeries, Zen will get the pressure down. And I think that's probably why, like, you treat glaucoma, you're trying not to reoperate. That's the whole goal. So you're picking a surgery where you're not going to have to come back and do something more. And yeah, and then the safety profile, like we can treat them earlier in the disease, and that's kind of been the goal for all of us. That whole interventional mindset is to, we're always like, patients aren't compliant, and we like blame them and like, gosh, they just don't take their drops. Well, did we ever think it's because we just don't have great drop therapy options? Like if they were so good, people would take them. Like people take their Viagra because it works and it doesn't cause a lot of side effects. And the reason why we start going to surgery is we're trying to take that burden off the patient, but you don't want to do that when the surgeries are unsafe. And that's exactly what you're talking about. And I am fully on board. And when you're looking at subconch filtration, man, that's the one device currently that we have that's approved.
Yeah. So just a lot of great thoughts there. One, you know, like when I meet a new patient, I basically tell them goal number one, I don't want you to go blind.
Mhm.
Goal number two, I don't want you to have a trab or tube if we can avoid it. And so that's, you know, you're going to achieve goal number two if you intervene earlier
Mhm.
with the standalone stuff. And then the point, you know, so we know Zen does both IOP lowering and med reduction from, you know, Grover's study, and we've all seen it. You usually go from 3.5 meds down to 1.5, and then you take the pressure from 24 to 16. Um, in my experience, trabecular MIGS, if you're operating in the range of, say, borderline pressures 21, you get a few millimeters of mercury, and then you get med reduction. But you know, you just don't get that 9 millimeters typically, right?
Yeah.
You got to set that expectation if you're going to do trabecular MIGS. And I think that's what we struggle with, is because we want to get people off drops and with a pressure of 10. And it's probably not realistic with most trabecular standalones.
Right, and that doesn't mean that it's a failure if it doesn't do that, right? Because there is like a union between medicine and surgery, and as much as like we don't like the drops, that's kind of what gives us that buffer to have safer procedures. If you shoot for the moon for pressure reduction, we've all seen what can happen with trabs, and there's a good chance that you could overshoot. Whereas Zen, I mean, you know, just think about how many hundreds of cases that you've done. Um, I still don't have one that has had to be revised for chronic hypotony. I have drained choroidals once out of hundreds of cases, and a very thin, frail 90-year-old female with a pressure of 30 on 5 classes of medication and a high dose aspirin. That's the only choroidal I've drained. And you know what? She's actually at a pressure of 6 about a year out from surgery. And she did fail a prior phaco TM based procedure. And I think probably my biggest pet peeve, and I know you've heard me talk about this, but we focus so much on like what goes wrong and what device does, how bad it was doing this. It's very easy as a surgeon, and when I teach and talk to like our residents when they're learning phaco, it's very easy for me to botch a surgery actually, and then it'd be even easier for me to come out on the flip side and say, yeah, you see, the surgeries just don't work. But what's very difficult is to find out, well, what were your successes and what was it about that case that you did, that you selected for, how you treated it, how you placed the device. You got to focus on that. Even if it's an N of 1 out of 100, if you hit a home run, how can you replicate that? And when surgeons start out with some of these mixed devices, they will see failure. We did. I even wanted, like my mindset, I even wanted to give up sometimes. But if you don't have that drive, or at least that perspective to say, look, there's still some patients that are doing remarkably well. How do we maximize that? Which is why our needling rates went from like the mid to high 30s to in the 25% range, consistent now. Our re-op rates at 1 year are around 10% or less. And I tell people, you know, if you're doing like say Zen surgery and your pressures aren't around the 14, 15 range, and on average, like maybe 1.5 medications at a year. And if you aren't getting a re-op rate that's around 10% or less, and your kneeling rate's higher than like 25%, you should start considering changing your technique because that potential is there. But imagine like when you have your first posterior capsule rent or drop lens when you're a resident, and there's no one who has that perspective. You know, experience in medicine and probably in life, all it does is actually give you perspective to kind of know where things can get to. And I think that's probably the most important point for like teachers. Like you keep telling them, look, phaco is a good surgery. Yes, you had this really bad complication out of your first 20, but it's good. There is light at the end of the tunnel. And it's the same thing with MIGS, because again, very minimal energy to be negative and a naysayer, but a much different mindset and energy that it requires to actually push the thing forward.
You know, you're making such a good point about, we also tend to oversample our failures. So if you think about your average day, you know, the 4 people you operated on who have pressures of 8 and are off drops, they're home. They're not
Yep.
coming to see you. And, you know, the same thing, I did a you know, multifocal IOL last week, and there's a little problem, and I'm seeing the patient. And I just have to remember, you know, I've done plenty of these lenses where they're gone. In glaucoma, we see our complications so often. And with Zen, actually, a couple of times I, you know, got frustrated and sort of took a step back from
I
Zen.
remember that with you, man. I totally remember that. And you're one of the guys that like loves to push and pioneer.
Yep. And then they all started coming in. I stopped seeing the patients I needed to needle, and I started
Yeah.
seeing all the ones who were doing great for their 6-month visit. And then you remember, okay, wait a minute. I've been focusing, this is too myopic here. And, there are very many happy patients. And that's actually why it's nice. I reviewed a series of my own patients, ab interno traditional technique versus a conjunctival dissection a la Joe Panarelli, ab externo. And I had great results,
Mhm.
but until I put a database together, and I got the same thing. It was exactly like Devinder Grover's studies, 3.5 meds down to 1.7, huge 9 millimeter pressure reductions, plenty of people with a pressure of 10 off drops. Um, Looking at your data though, you see that better than in a clinic where you kind of, yeah.
I totally agree. There's a doctor, Javier Campos, good friend, practices super high volume, like Northern Canada. Okay. And he's on an island. Um, and, we always text about like frustrating surgical outcomes, but that's exactly right. They are so heavily weighted to your clinics, like that you see routinely. And then he analyzes data at a year and he sent it out. It was to me and Manjul, who, is out in Michigan. And the results were just like complete opposite of what his thoughts were about the device and procedure because you just see some of the few ones that you have issues with. And I think we're like, the Zens don't really have issues in the same way of trab. One of the ladies I'm managing right now, we did her trabs bilaterally maybe 2.5 years ago, and she's normal pressure glaucoma. And by that I mean like she was progressing at relatively like mid-teens pressures, and I'm not so sure that they always need a single digit pressure, but both sides had achieved something pretty good. She's doing well. Comes back left side now, hypotony maculopathy 2 years out. Bleb looks about the same, but as we get older, we make less aqueous. If we don't have these types of things to help prevent the chronic vision loss that could happen, chronic hypotony, you're not treating patients like you should, and that's why that safety profile is so important. And I don't get that with Zen. Like I said, I have never revised a Zen implant because of chronic hypotony. And maybe it'll happen, but I mean, you're talking about now hundreds of cases. And when we publish our own data, we've kind of got multiple centers now. It's probably 300 or 400 cases so far that we've collected. And I'll tell you, they're actually at our center biased toward more negative results because the ones that are doing well, we discharge them back to their referring doctor. And I don't see them back. So really the only ones we're managing are the ones that might be on medicines or we're not sure if their glaucoma is stable or not. And I think that's the other thing that people don't realize when we publish these things, like that's the other perspective to look at. And I always say this, I can't hide. I can't hide behind my fellows and residents. They are there in clinic with me. They see what's going on. If I am doing something truly because of whatever influence people might think there is on the outside, I can't get away with that. And there's a very distinct difference, and I hope people actually see that. Like, but yeah, it's been rough at the beginning, but now, you remember when it was kind of had a pause last year for a couple of months? That really impacted our practices, and we didn't think that it did until it happened. We're like, what? Like we were relying on this more often than what we realized. Did
Yeah.
you notice that?
Right. Yep. Yeah, we had a little manufacturing, reset there. And yeah, I missed it and was excited to get back to it. And you realize it's bridging that gap, the gap we all talk about. I wanted to ask you, is there a way for standalone MIGS and kind of bringing these patients in? Is if you have a referring doctor, like, is there? So let's say you're working with an optometrist who just says, look, which patients do you want to do standalone Zen on, and how can I get them to you? What would you kind of paint the picture you'd sort of recommend for referral for this type of procedure?
Yeah, I guess to simplify it, it would really be patients that are kind of in like two bigger buckets, and you're putting me on the spot here because I want to make this as like simple as possible. It's the ones that are potentially controlled, but just for whatever reason, their drops, they're not tolerant. Like, 3 or 4 classes to keep them at a pressure to keep them stable. But whether it's cost, compliance, or just irritation, they can't do it. I wouldn't feel very confident in a stenting procedure in the TM to get them off medicine, just flat out. And it's going off of data and it's going off of our own data. And that's a very clear cut Zen candidate for me because remember, we're now approaching this for medication reduction. you have to have a good safety profile, like you mentioned. Like, I don't want to do a tube in that patient. I don't want big hardware, and I don't want to do a trab in that patient. The other one is the patient that is just borderline. Maybe they're progressing, maybe they're not. You're not quite sure about their glaucoma status, and maybe that patient's a little bit more motivated. They're nervous about their disease condition. I mean, this is like a very psychologically like taxing condition because it's so silent, and all they know is there's a problem, and they might not be able to know when things are really bad. But you don't want to subject that patient to something that is that aggressive of a surgery with high risks of complications, and that's another Zen patient. But probably the easiest way to answer your question, Nate, actually is, who would I not want to do Zen on? I don't want it in a uveitic, and I don't want it in a neovascular glaucoma, and I don't treat angle closure with filtration surgery unless the angle's been open. And so anyone in that is outside of those patients, I'd say they are candidates, especially if you feel like their disease is not controlled or they're having issues with meds.
Those are perfect thoughts. And I agree with you completely. So, I think I want to thank you for coming and helping us join this
It's
conversation.
been fun, man.
And I'm gonna bring all this back to clinic on Monday, and again get back on the horse, because ultimately there's just a disconnect between what we know to be true, which is our patients are sort of silently suffering on too many drops and they need help, and our actions. And
Nate, you nailed it. But wasn't it Budenz's paper when they surveyed AGS members? How many of them in their own eyes wanted like a trab or tube compared to a MIGS surgery?
yep.
And the AGS members would prefer MIGS options in themselves, and that is the disconnect. And I've kind of been public about this, but just having treated physicians and glaucoma specialists with glaucoma, um, one of which had very bad complication with a trabeculectomy as a resident, and he's been public about this. He's the one that kind of like enlightened me. He's got bilateral Zens now, and one of the eyes that had failed a trab in a revision after it was hypotenuse, and then the post revision was like a pressure of 50. The guy was on Diamox for years, practicing. Okay, um, you look at those, and you're like, one of us could be on the other side of the slit lamp one day, and you got to think, what would you really want in yourself? And I don't like when patients ask me, well, what would you do, doc? Because I'm not them. I don't know their risk tolerance. I don't know their activity level. I don't know how things are at home. But I can tell you, I know what I would do for myself, and I know what AGS members would do for themselves.
Yep.
And that's where the disconnect is. And that's what's unfortunate. And I really like credit AGS leadership, actually. And I'm pretty sure it was Don Budenz, man. Check me on that. But that was a great survey and a great paper that they put out.
Yeah, agree. And it's true. Anytime there's a gap between, how we would want ourselves treated and how we're treating our patients, it's up to us to close it.
That's exactly right.
Great thought. Okay, well, thank you, Arsham, for joining us here.
Thanks, man. Let's do it again.
Yeah, thank you. Definitely.